presenting a case of female 52 who come to me with stones, bones, groans, thrones, and psychiatric overtone symptoms like patient having history of recurrent stones, polyuria, polydipsia, nephrocalcinosis, bone pain, abdominal pain, peptic ulceration, constipation, nausea, and vomiting, with frequent urination and having fatigue, depression, and irritability. This patient also having some psychotic symptoms. This patient having history of stone surgery two times within 6 months. On examination, this calcium level is showing 16 while parathyroid level is 3000. On USG of the right neck swelling showing about 4 is to 3 centimeters cystic swelling on the right thyroid region. And systemic skin showing diffusely enlarged right thyroid and parathyroid lesion showing right parathyroid adenoma invading into the right thyroid lobe. This patient also have history of hypertension and there is short QT interval on ECG and there is proximal muscle weakness is also there. So in this case I plan right hemithyroidectomy with right parathyroidectomy. That may be a case of adenoma within intrathyroidal or inseparable from the thyroid tissue and may be a coexisting disease of thyroid nodule. So I plan surgery, hemithyroidectomy and right parathyroidectomy in this case. So operative finding are there is right inferior parathyroid adenoma is there just embedded or attached to the right thyroid lobe with right thyroid lobe showing thyroid nodule and there is clearly you can see just beneath the tubercle of Zuckerkandal this thyroid adenoma is attached. So final diagnosis is primary hyperparathyroidism due to intrathyroidal parathyroid adenoma treated with right hemithyroidectomy with parathyroidectomy. You can see clearly recurrent laryngeal nerve in the bed of the thyroid tissue. I am separating the parathyroid adenoma from the thyroid tissue. This is caramel color. You can see under microscope clearly the color difference between thyroid and parathyroid. Whatever I am holding with the forceps is the tubercle of Zuckerkandal. Just beneath it is the this adenoma. If you put in the water, this adenoma will sink in the water while the fat will float. I have taken fat from the bed of the thyroid to see if I left any tissue of parathyroid from the thyroid bed so that I can differentiate clearly there is fat only, no parathyroid left in the bed of the thyroid tissue. If you put this all three tissue in the water, the fat will be float while this parathyroid adenoma will sink. You can see it is sinking and as well as this fat is floating and thyroid tissue also sink in the water. You can see clearly. After 10 minutes of removal this parathyroid adenoma, we send blood report showing parathyroid hormone level is 248. That is almost coming more than 50% of previous finding that is about 3000. So this suggests you have removed the parathyroid adenoma. On second postoperative day, parathyroid level was 19.64, calcium was 9.96, while on postoperative day 3, calcium was 9.61. These reports are within the normal limits. And histopathology showing both extrathyroid or intrathyroid parathyroid adenoma. As you can see, this parathyroid is the report of the extrathyroid tissue which I have cut. And this report is showing inside the specimen of the right hemiparathyroidectomy that is showing parathyroid adenoma. This double adenoma is very rarely seen as pathologist was confused. So she has done this immunohistochemistry and showing this labeled marker of the parathyroid. And double parathyroid adenoma general incidence which are extrathyroidal is about 2 to 11%, while this exact incidence of this one parathyroid is extrathyroidal, one is inside the thyroid is very rarely seen. So double adenoma with intrathyroid or extrathyroid is exceptionally rare case. So this case, I think it's very extremely rare case. So I am presenting this case to you. This real picture is given by Dr. Bipal Parmar of Supratech Lab. Thank you so much, ma'am, for providing me real picture of this patient. Thank you so much.